Good morning, and I want to first thank you for coming this morning to this press event that's going to highlight a report that our organization, the National Association of Community Health Centers, is going to issue today. It's going to discuss the threats that America's health centers face even as they celebrate our 50th anniversary. I am, by way of introduction, Dr. Gary Wiltz. I'm the chairman of the board of the National Association of Community Health Centers. I'm also the CEO of 10 FQHCs located in Southeast Louisiana, known as the Tesh Action Clinics, home based in Franklin. And I've been the CEO now for over 20 years, but I've been at the center for over 30, and I'll talk a little bit more about our center and some of the things that we do. But to get the event started, what I'd like to do is to call up to the podium the Senior Vice President of Policy at our National Association, Dan Hawkins, who's going to go over the report, some of the details, and then we'll follow in order. So thank you again. Dan?
Thank you, Gary. You know, Gary didn't mention that on top of everything else, he's a physician who provides regular pay. I won't even ask you how many hours a week you spend in patient care versus administrative stuff, but and just a fabulous, fabulous example of the multitasking, multi-talented folks that we have in our health center family all over the country. I want to say top of the morning to you lads and lasses. On this fine St. Patrick's Day, we're out here enjoying the beautiful weather and each other's company, and that's always good. I want to thank you for participating in today's event. As Gary mentioned, I'm the policy director for NAC, and I am pleased to provide a brief summary of our research report, which you have in your packets. You know, as we celebrate Community Health Center's 50th anniversary this year, they are projected to serve 28 million people by the end of this year. We're at 23, 24 million now, but the government projections from HHS are that they will reach 28 million by the end of this year. That is a phenomenal growth rate, but totally appropriate in light of the other changes that are washing across the healthcare system in this country. These patients receive care through 1,300 health center organizations. We have 4 of them represented here this morning. Through healthcare sites, you heard Gary talk about how many? 10. 10 sites operated by his health center organization. Yep. There are 9,200 sites where healthcare is provided by these 1,300 organizations across the country. And those are, most of them are in individual communities. So we like to say health centers serve over 9,000 communities, rural and urban, all underserved. Health centers integrate medical services with oral health, behavioral health, pharmacy services, vision care, and other key services as well. They improve access to care by removing barriers to care, such as the cost of care, lack of insurance, the distance one has to travel by being located in those communities closer to the homes of these folks, language, transportation, whatever the barriers are that get in the way of people seeking and getting the kind of health care they need. That's what health centers are focused on helping them overcome and providing. And although every health center must meet the same set of federal operating requirements, each health center is unique, adapting its model to serve the needs of the people and communities they serve. And you'll hear that from the members of the panel this morning. So what began as a unique sort of innovative social experiment in the mid-60s has evolved into the largest primary care network in America today, improving the health and well-being of their patients and communities while lowering overall healthcare costs for the people they serve. Note this, health centers generate, according to official peer-reviewed studies, more than $24 billion a year, that's billion with a B, in savings to the healthcare system, to taxpayers, private payers, everyone, through efficient patient management. On top of that, they also create jobs and bring over $26 billion a year in needed economic activity to the inner city and rural communities they serve. Now, at the heart of this success story is the sustained public investment that has sustained and strengthened community health centers over the course of the past 5 decades. Federal support has also positively benefited the U.S. healthcare system. Health center funding and capacity have been proven to lower emergency department utilization among the populations they serve, and that typically have few alternatives for getting the care they need. They've also lowered the rate of specialty referrals by keeping people healthy and on the job, keeping kids healthy and in schools, et cetera. And this includes patients who are overwhelmingly, and this is the remarkable thing, low income, overwhelmingly low income. 93% of the millions of people served by health centers today have incomes below twice the federal poverty level. 71% have incomes below poverty. It is this record of accomplishment that has drawn bipartisan support for the program in Congress and in successive presidential administrations. President Bush called for doubling the size of the health center program as he ran in 2000, and he kept faith with that commitment over the 8 years of his term. President Obama came in and said, I'm going to double this program again because we're going to need you as people gain insurance coverage and need a place to go. However, and that's the key, the current threat to federal health center funding jeopardizes their ability to sustain and grow these successes in access, outcomes, and cost, and therefore poses a very serious challenge to our overall healthcare system and the American economy. So without action by Congress this year, the Health Center Fund, which was created in 2010 to improve access to care, is slated to expire on September 30th, leaving only the discretionary funding that health centers have received previously to cover the program's operations. What this would amount to is a 70% loss, 70% cut in the federal grant funding they receive. If this cliff is not addressed by October 1 by the Congress, according to the report and the studies that have been done, an estimated 7.4 million of their 28 million patients will lose care in the first year, and nearly 57,000 clinicians and other health center staff would have to be laid off. More than 1/5 of the 9,200 healthcare sites would be closed altogether, or could be. By 2020, just 5 short years from now, the number of patients, fewer patients that could be served, rises to almost 10 million, and almost 82,000 positions at health centers would be unfilled. As the research report we are issuing today makes clear, losses in federal funding would dramatically unravel not only the recent progress, the past 5 or even 15 years, but 50 years of achievement, resulting in a loss of care for millions of patients, layoffs of clinicians, health professionals, and other key personnel at a time when demand and need for primary care is increasing. There's really too much at stake to turn back now. And while I think that many here are aware that I know whereof I speak, because actually when I had a real job, I ran a health center years ago down in South Texas for almost 8 years. That was just too long ago. So it gives me great pleasure to introduce our panel of 4 experts today who work at health centers and who can speak to both the significant accomplishments of their local health center operations and the terrible toll that any loss of this federal funding could exact on their communities. The panelists are Dr. Gary Wiltz, who, as you heard a few moments ago, is our National Board Chair, as well as the CEO of Teche Action Clinic. That's T-E-C-H-E. And it's a Native American word for snake. Ain't that beautiful? In Bayou country, snakes are beautiful. So Gary will speak of his experience. Mr. Henry Taylor at the end of the table is the CEO at Miles Square Health Center in Chicago, one of the nation's oldest original health centers. I think it was the 3rd or 4th health center correct. Opened back in 1965-66. And it is a lifeline for the people of the near west side of Chicago. Yvonne Davis, our community representative who chairs the board of directors. Remember that every health center is governed by a community board, a majority of whose members are registered patients who actually receive care at the center. And Yvonne will speak to her experience and note that she has been active for over 20 years in the health center movement and was recently elected as the consumer representative on our national board of directors. So these guys will be spending a lot of time together, right? And finally, Marilyn Summerford, who is the CEO of Access Family Health Services, a vital healthcare source for rural communities in and around Smithville, Mississippi. We all know where that is, right? Beautiful country. It is God's country, including, by the way, I might add, a great dental program, which I think is at risk, and care for multiple hundreds of veterans as a VA community-based outpatient clinic, or CBOC there. Each of them will speak to their experiences and what the implications of losing that federal funding might be to their operations. So we'll begin with Dr. Wills.
Well, thank you, Dan. Lord Alfred Tennyson said a number of years ago, "'Tis better to have loved and lost than never to have loved at all." Well, that may have been true and be true for love, but it's not true for healthcare and access to healthcare. The cruelest thing that you can do is to have someone, and we've experienced this, come into the system who previously had not had access to healthcare, provide them healthcare, and then take it away. Dan talked about the numbers, the national numbers. What I'd like to do is put a face to some of these numbers that we talk about. Now, I'm going to drill down to local level what it means for us in our centers. As he mentioned, we operate 10 community health centers throughout Southeast Louisiana. In the last 5 years, we've been able to double our expansion and access to care in the communities that we serve. I can't tell you the gratification that you get, and someone like myself, I'm an internist, and I've been at our site for 33 years. I came with the National Service Corps. I had a 3-year commitment, and now it's 33 years later, and I'm still there. The point is that these are not faceless names. These are real people, hardworking people, who for the first time, a lot of them have now entered the healthcare system, and they now have a healthcare home. In our system, with a 70% cut, we are slated to lose. If we could lose 70% of our funding, it's going to affect 4,400 patients. We cannot absorb that type of cut. No one can. That equates to about $2.7 million for us. As you see, Louisiana is a very poor state. We have about 4 million total people in the state. Over 1 million are uninsured, and almost another 1 million are on Medicaid. So it's a poor state. And the impact that we've had, and we've celebrated 40 years of existence at our center just last year. These are people like one of our board members, and I know I've gotten his permission. His name is Howard Castaigne, and his wife, Darlene. Hardworking people. He actually is the owner of a radio station. As most of our patients are, they're hardworking people. A lot of them work domestic jobs. A lot of them work sub-minimum wage jobs, and they can't afford health insurance. But through the last 5 years, we've been able to open centers in areas that the need was great. So I can't tell you how it feels to have, for the first times in their lives, the security of knowing that you have health insurance coverage and access to a medical home. And that medical home is a place where you can come, where we actually know your name, like they used to say in Cheers. And we actually are glad they came, because in the last few years, we've picked up people that were severely hypertensive, people that had uncontrolled diabetes, people that we found with colonic polyps that were the precursors to colon cancer. And so we've been able to make a tremendous difference in their lives. We knew 50 years ago when the whole program started that access was always the problem, and access is still the problem. Dan quoted some statistics. If you knew the numbers, we're serving about 1 in 17 to 18 maybe people in America right now. We're at a crossroads in our country as far as the community health center program is concerned. If the funding cliff is fixed and funding is restored, there's some projections that Hearst has put out that say that we probably can serve up to 28 million in the next year or so, and over the next 5 years, up to 40 million. If we're serving 40 million people in this country, that means we're touching about 1 in 7 Americans. And I think that speaks volumes. If the other road is chosen, if this funding is not restored, 7.4 million people stand to lose. We cannot afford to go backwards. It's the cruelest cut of all to have something in your hands and have that access and then have that taken away from you. I've had to sit by and see folks. We're in a state that did not take Medicaid expansion. And as you all know, we did outreach and enrollment. We have certified application counselors. We brought patients in. We went through the health insurance exchange. Some of them would have qualified for Medicaid. Over half the uninsured that we treat would have qualified for Medicaid, but because we didn't do expansion, they didn't get Medicaid. But we are still there. The sites that we just opened, the last 2 sites that we're open, we're running on average 80% uninsured patients. Now those folks have access to have a medical home. So when I want to close by just saying that I guess the most salient point to me as a treating physician and going into the exam room with folks is that, you know, the peace of mind that we've provided historically for 50 years and the accomplishments that we've been able to do in the last few years through the generosity of Congress recognizing the need for what we do and the patients we serve is at stake. And if we don't correct this, it's going to have real impact on real people and real lives will be lost. So, and I know we're going to have a question and answer after that. Now I'm going to call Henry Taylor to the podium and he'll give his story. Thank you.
Thank you, Gary. Good morning. I'm Henry Taylor, the CEO of the University of Illinois Miles Square Health Center. Let me begin by telling an American story. Approximately 50 years ago, President Johnson signed the War on Poverty, which began the birth of the Community Health Center movement. Community health centers have become a vital component of the health care delivery system in the United States, serving 23 million individuals. It is estimated that 96% of congressional districts have a community health centers within them, which is an amazing task. In Illinois, 1.2 individuals receive their primary and preventive health care at a community health center. This is unique because community health centers are managed by a governing board. 51% are required to be users of the health center and members of the community. Governance by the community and for the community. If Congress does not act, as you've heard, health centers are poised to lose 60 to 70% of their federal funding. So the question you might ask is, what does this mean for Miles Squared? What does this mean for the state of Illinois? Illinois today receives $115 million in federal funding. Illinois could lose anywhere from $68 to $81 million in federal funding. $68 to $81 million in federal funding. 134,000 patients would lose access to preventive and primary health care. I'm challenged as the CEO as how Miles Square, which has 13 health centers throughout the Chicagoland area, 5 regional health centers which serve large community locations, 5 school-based clinics that keep our children in school, and 3 behavioral health clinics that serve patients with chronically mentally ill, patients with chronic mental illness. How do we sustain a cut of this magnitude? Miles Square today receives $2.9 million in federal funding. This would net about $2 million in cuts to our funding. Quite frankly, we will lose providers, we will lose staff, We would lose our ability to become and sustain our ability to be an economic engine in the community. But plainly put, I would have to close a site. Close a site. We have regional health centers, and this will become clearer to you as I go on. There are 77 communities in the Chicagoland area. Miles Square reaches 51 of the 77 communities. There are 77 communities in the Chicagoland area. We're able to reach 51 of those 77 communities. 1.9 million individuals reside in the Miles Square service area. Over 50% live below 200% of the federal poverty level. Just 25% live below 100% of the federal poverty level. 9 of the 51 community service areas we serve are of the extreme poor, with over 40% of the residents living below the federal poverty level of 100%. So the question you might ask is, how do you dare close a site in one of these areas where the need is so great? What does it say to me? I'm proud to be the executive director, CEO at Miles Square Health Center. It said to me, we've been true to our mission. We were deliberate in my 17 years as CEO of being where the most need is required. We were deliberate in ensuring that our board approved the site, each of the sites we went into. Now, it's not only just the sites, it's the care that's provided that's so vitally important. The Health and Human Services Administration, HRSA, was ahead of the curve when it came to population health. People don't speak much about it, but that's the truth. There were collaboratives developed over 10 years ago. You may recall that, Gary.
Absolutely.
We focused on improving the health of the individual. The communities we serve have high degrees of hypertension, diabetes, obesity, asthma, and mental illness. We want to cut $2 million out of our budget. We want to close our sites. But yet, our communities, there's 1.9 million individuals. We're just beginning to scratch the surface. So we need your help to help us deliver care and continue with the American dream. This is an American story. This is a story about keeping America strong. And I thank you.
Good morning, everyone. Now, you've heard the numbers, and now my story is because I am the patient that's included in the numbers that they were all just speaking of. And here's my story. I am from the state of South Carolina, and yes, I know those have heard it before. After 34 years almost, I'm retired. So it gives me a great opportunity, and I'm so excited to be here today to share with you just how important community health centers are and have played in my life. Back in 1985, the love of my life, who at that time was 29 years old, he suddenly died on my daughter's birthday. Why? I had no idea. But it was a mental block that was put upon me that I couldn't understand. He and I had been with each other since we were 5 years old. But we were planning our daughter's birthday, 10th birthday. But he was never there to attend. Several years later, my brother, who I've testified before, that he lost life himself. His entire family was taken away from him. His son, after he was recovering from cancer, they removed the portacath, and 10 days later, he was killed in an accident. 6 months later, his wife was diagnosed with an illness, terminal illness. And 3 months later, my brother, his oldest and best friend, died. My brother silently tried to commit suicide. At that time, he worked at the industry. Industries were booming in our town. He'd been working there for 20-some years. Then insurance went away. All of the industries went away. There was no medical attention. So when I laid eyes on him and I told him, I said, listen, you have to get to the community health center. there's a place for people like you. So I scheduled an appointment with him, and boy, am I glad that I did. By the time he was examined by the physician there, we had 40 minutes to get him to the closest emergency room. They were wanting to call an ambulance because they said that he had had a heart attack and he was in serious condition. And of course, we went there, went straight through triage and straight up into the intensive care unit. It was because of the community health center that was willing to see him as a patient. He had no insurance. And the physician in the emergency room said, I'm not sure who that lady is that looked like you, but she looks too much like you to be your wife. But you have her to be grateful for because you would not have lived 72 hours. He went through a quadruple bypass. I've got family and friends because of in my hometown of Marion, South Carolina. We're about 45 minutes north of Myrtle Beach. Because of that, I've had friends that are saying, we don't have dental care. And just 2 weeks ago, a loved one of mine, where he went to get examined, and they told him what it had needed to happen. He hadn't been to a dentist in 10 years. And you can't even imagine that. And when they went to do the molding for the teeth that had been missing, the others came out in the molding. So when you talk about cutting the funding for community health centers, that's just almost unheard of. That can't happen. Community health centers give communities like mine and others hope. And we have to keep hope alive for all. And it's not just because of Marion. I know I speak for a lot of the consumers. I am a consumer before I am a board member. Yes, I've been on the board for 20 plus years. And yes, there are barriers and obstacles and places that nobody wanted to go that I wanted to go to spread the word of how important community health centers are. School-based clinics in my county was very effective. What we did was teenage pregnancy went down. STDs went down. It was good. Life was great. So when you talk about cutting the funding, that can't happen. It's almost going backwards instead of progressing. So I say to the powers that be, here's my plea from your constituents. This is what we're asking. We need the federal funding to be able to sustain that the communities will have what it takes to live productive lives. And it's a right that they have. You have to be healthy to do just about anything you do. And if you're not, then what do you have? Your life is just at a standstill. I've learned to be grateful and appreciative for all community health centers for what they've done in my life and others that have witnessed and felt the need to advocate as well. And I thank you all for coming, and I am glad to have had this opportunity. And I'm looking forward to doing whatever it takes to speak to whoever it needs to be hearing what I have to say. Community health centers are the bomb. Thank you.
Very good. Very good.
I'm Marilyn Summerford, Executive Director of Access Family Health Services. I've had the privilege to serve in that role for 20 years, and when Gary said access is the problem, I'm like, no, access is the answer. That's what we've heard for years. But Access was chartered in 1978, and in 2014, we're a very rural group of health centers. We provided services for 9,355 patients with over 30,000 visits at 5 delivery sites that are primarily in rural areas of Northeast Mississippi. If you look at the demographics of the patients that we serve, it's not typical of a community health center because about 66% of the patients that we serve are males. That's very untypical. And then about 35% of those are over age 65. But you see, Access serves over 4,300 veterans that are enrolled through a managed care contract with the Department of Veterans Affairs. In 1998, the VA Medical Center in Memphis was trying to improve access to care for a large population of veterans that lived in Northeast Mississippi, and many of those were elderly and they were unable to travel to Memphis for care. Many of those veterans had never received health care that they were eligible for through the VA because they just couldn't make the trip. At that time, the VA's primary care clinics were packed with patients. They had to wait long amounts of time for their appointments, and they had to wait long periods of time to get appointments. But, you know, we weren't sure at that time if we were up to the challenge, but we knew that, that we could not afford to give it our best shot. The odds were probably against us at the time because we didn't have the staff, nor did we have the experience. But what we lacked in experience, we made up for in passion. And the collaborative partnership that we enjoy with the VA has been one of mutual trust and respect. And as a result of this, we've seen the quality of care that we deliver at our health centers improve, and we've seen access to care improve for those veterans. And at the same time, we've stayed true to our mission, which is to provide affordable, comprehensive health care and education for our communities with superior service. And we've also helped the VA carry forth their mission to care for those who've borne the battle and for their widows and for their orphans. But one thing that we do extremely well as health centers, I think, is to leverage all the resources that we have and to serve everyone in our communities regardless of their ability to pay. As Gary mentioned, we provide medical homes, and we welcome the opportunities to benchmark our performance against other community health center providers throughout the country and other community providers. We are economic engines in our communities, but we have to operate as businesses, and it's very difficult to operate as businesses, to grow and to expand when so much of our funding is in jeopardy. As Gary is in the state of Louisiana, Mississippi chose not to expand Medicaid, and we have provided outreach and assistance for those seeking coverage under the Affordable Care Act. But we've seen so many fall in the coverage gaps that don't qualify for subsidies. And if they don't qualify for the subsidies, then they're unable to afford insurance. About 93% of the people in Mississippi that are enrolled under the Affordable Care Act receive the subsidies. And far too many of the patients that we see remain without health insurance, like the single mom who works as a hairdresser. Because she had no insurance and was diagnosed with breast cancer, she had to work out a payment plan at the local cancer center so that she could receive her treatments and that she could continue to support her young son. And these are the stories that we hear day after day. And it's not just medical care. You've heard some of the others mention the dental program. You know, we can't, as we look at providing the holistic care, we have to consider all of the needs of the patient. According to our state association, through their website, the largest number of inquiries that they receive are for patients that are needing emergency dental care. Patients that don't have money and don't have dental insurance often end up in the hospital emergency rooms. About 96% of the patients that we serve in our dental clinic are either uninsured or they have Medicaid. And the type of cuts that you've heard discussed today with the health care funding cliff would most likely result in us having to do away with our dental program, that program would no longer exist. And we have patients routinely that drive 100 miles for dental care. That's not unusual at all. So where would these people go if they lost that service? I think the residents of our communities understand more than most the importance of a community health center, because on April 27th of 2011, our main site, along with most of our town, was destroyed by an EF5 tornado that hit the community at 3 p.m. on a Wednesday afternoon. There were more than 30 patients and employees and guests in our health centers at that time. and they found safety within the Access clinics during that terrifying storm. There were 16 people that were killed in the community, but our staff was able to go out in the community before the ambulances could get in and to provide immediate aid to those people. And Access weathered that storm, and in June of 2014, with funding that we received from HRSA for capital development, we dedicated a new 12,348 square foot clinic. But today we face a different kind of storm that we refer to as this health center funding cliff. For 50 years, health centers have been a place of safety. And many health center sites and many health center services, such as our dental program, won't survive if this health center cliff isn't fixed. You know, there's one thing that we've learned over the 17 years that we've served veterans, and that is that you don't quit in the middle of a battle. So we're going to keep fighting, and we ask you to join us in that fight as we help assure that all people have access to affordable health care over the next 50 years.
Thank you, Marilyn. Thank you, Henry, Yvonne, and Gary, I'll just call you Gary, for incredibly moving comments. Oops, there goes my water. Thank goodness it's still got a cap on. Incredibly moving comments, and particularly you, Yvonne, talking about the folks in your community, relatives, and others who rely so heavily on the work that health centers in your community and all over the country do. These are just 4 snapshots of life in the communities that health centers serve and are located in, and the vital importance of that. You know, about a year ago, in this area, and I think it's happened in other places around the country, Mr. Stan Brock, I don't know if you know of him, but he's the one who conceived of and today still operates something called Remote Access Medical, or RAM. Literally clinics, almost pop-up clinics with volunteer physicians and dentists who come into a community, typically rural communities. In fact, they often tend to set up shop at racetracks throughout the South where the need is so great. Gary, you know about that. Yeah. Yvonne, you know about that. Yes. And Marilyn, you know about that as well. To provide care over the course of a long weekend, sometimes 16-hour days, to people who are so desperate, whose need is so great and really have no place else to turn. Stan and I testified together before a Senate committee overseeing primary care and access to care issues. And I remember Mr. Brock saying to the chair of that committee, Senator Bernie Sanders, please grow the health centers program. Please put us out of business. He said, I started Remote Access Medical overseas, in South America, in Africa, in places where healthcare is so scarce and so desperately needed, and then found out I needed to do the same right here back in the USA. Please put us out of business by making healthcare accessible and affordable for everyone. And I remember turning to him and saying, Stan, it may take a while for us to get there, but we believe in this program, we believe in this movement of health centers, and don't fault us for not trying, because we're trying awfully hard. Stay with us and believe in us, and someday we will get to the point where something like Remote Access Medical will be an anecdote or an artifact of history. We're not there yet, unfortunately. So let me open up the floor for questions. If anybody has questions of myself or any of the panelists, not only on today's report, but any topic, we'd be happy to take them. Yes, ma'am.
Hi, I'm Emily Jones from the Assistant Secretary for Planning and Evaluation at HHS. Thanks. I'd love to hear more about how the possible cliff would impact access to mental health and substance use services in health centers.
You know, we didn't talk a lot. The question, as you heard, is what would the impact be on mental health and substance addiction services? About, the last time I looked, somewhere in the 70% range of health centers are offering really what we call behavioral health, which is really mental health, counseling, guidance, assistance, emergency information, and substance addiction services as well. And I think, I'll bet, Henry, you offer those services, and perhaps someone else does. What would happen if you lost 70% of your grant funding to the behavioral health services you offer?
Very good question. Let me first begin by saying Miles Square, University of Illinois, provides integrated behavior health to some of the most neediest populations in the city of Chicago. This population, unknown to most of the American population, dies earlier than the average population, many years earlier than the average population. And why is that? Because many of these patients go for their behavior health, go for their psychiatry care. But the psychiatry care doesn't manage the behavior, the medical care. At our practice, we integrate the behavior care and the primary care together. So the patient gets to see their psychiatrist and their physician at the same time. Now, why is this important? When the patient has that trust with the psychiatrist, many of these patients with chronic illness don't navigate systems well. So we've learned through our literature that providing the services in tandem is valuable, driven by funding from HRSA. We just were fortunate to receive funding from the HRSA to expand our behavioral health services. To that end, there are two things you should note. In our country, behavioral health is underestimated. It's estimated in the city of Chicago, about 8% of our patient population has behavioral health issues. We know that's woefully underreported. We would have to, in fact, close a site and be very strategic about a site. We would have to close. When we were talking about a $2 million cut on our budget, that's about $20 million, $21, $22 million. As I said, it's hard to talk about cutting $2 million out of personnel. We have a lot of fixed costs. So the reality is that we would end up having to reduce services. And the reality is behavioral health is one of the undermet services, strongly undermet services in our country, and we need to address that issue. I hope that answers your question.
Thank you, Henry.
Let me just say that we're only now beginning to make some tremendous strides that Henry alluded to. In community health centers, we don't just treat part of the person, we treat the whole person. It's comprehensive in everything that we do, and you're absolutely correct. The life expectancy on that population is about 20 years less because of the comorbidities that they experience. But that's the beauty of having a medical home where you can get all of your services. It's like a one-stop shop. So not only can they be seen by the psychiatrists or mental health providers, but the medical personnel, dental and pharmacy on site, which is critical for them to get their meds, which is a huge part of what we do, as you know, through the 340B program. So it completes the circle. And if you disrupt that, and, you know, we're in the process right now of preparing our budget for the coming year. And I can tell you, when you start looking down at the numbers and you start looking at 70% funding being taken away, there's no way in the world anyone could survive that sort of cut. And you have to plan for just what we all have talked about, closing sites, laying off folks. But the most important thing are those people that we're now serving who now go back into a zone of not having access to care.
Marilyn, this is an important thing because you see veterans, and I'm sure you see plenty of post-traumatic stress disorder, traumatic brain injury, and other problems that are physical, but also psychological. Talk a little about the services that you're able to offer or coordinate for those veterans and what would happen in the event that the cliff were to hit you.
We began providing behavioral health services in 1995, and we too were successful last year in receiving a behavioral health integration grant. But you know, it's such a huge part of what we see with the veteran population, but the experience that we've gained from that has really given us, I think, an edge in that total integration that they have discussed. But you know, one of the things that we have been able to do through the VA and now through other sources is to utilize the telehealth. And that's something that is so new in our area that that the total system is not in place as far as we have the equipment, but to have those providers. So I think that this type of funding cut would be a huge step back, because most of the telehealth that we're seeing in Mississippi, which is a very rural state right now, is mostly through the hospital emergency rooms. And we feel like that we are poised that we can really expand the service, so that, because some people don't feel comfortable sitting face-to-face with a provider. Some people feel more comfortable, but it's a great option for those people that don't to provide telehealth in groups or telehealth individually. So even though Mississippi tends to be at the top of all the bad list, that is a list that we do rank very high in, is utilizing telehealth to reach the more rural areas of the state. And especially, that was our pioneer work, was with doing the telehealth for the behavioral health.
Can we drive that point home? Community health centers are not just running in place. We've never been about stagnation, and all of us have projected out over the next 5 years, expanding all of our services that we talked about, reaching that 40 million. So this enduring legacy, we're not stuck in the past. We have plans to expand telehealth through the teaching health center, which is also critical to this funding. That's going to produce more residency slots. That's going to allow us to train more people. We're having a very aggressive program that we're putting forward if we get the funding from Congress for teaching health centers. In particular, there's a program that we're looking at with A.T. Still University, training 1,000 physician assistants, all of whom are going to have mental health certification to deal with the Iraqi and Iran veterans that we know are coming back, and all of them are going to be needing some sort of service. So if you're looking for all the things that America wants, the triple aim, access, quality, and cost, we have a proven track record. We can even do more if we get the funding. Not only just to stabilize ourselves, but to expand and grow and meet the needs that America has right now.
And Dan and Gary, it's important. I would be remiss if I did not take a few minutes to talk about behavioral health in our children, our pediatric population.
Absolutely.
It's important. We were able to leverage our federal funding with some private funding to provide a behavioral health integration program for our children in school. And I'll tell you a brief story. And I sit as CEO, and I get a chance to talk to our providers. And one of our providers in my office and share with me that this child was hearing voices. And we were, in fact, providing care for this child. But in caring for the child, you have to be able to care for the entire family. You have to be able to care for the things around them that affect the things that create barriers to care, or things that create illness in the family. What I was struck by was the mom said, all this time I was hearing voices. She had no idea that she was suffering from a mental illness herself. But now we're able to provide that care for the family. These are the things that our federal grant, we don't give government enough credit. I'll say it out loud. We don't give government enough credit. I'm proud of our relationship with Health and Human Services Administration, HRSA. We could not do the things we do today if it were not for NAC, National Association for Community Health Centers. If it were not for HRSA to help us get the funding, and use those fundings to affect programming. But we have to deal with the whole person and deal with the whole family, not the individual. But it's important to remember our kids are affected by what happens in the house and what happens in the community. And when you have high incidence of poverty, it comes with violence, bad health outcomes, and many times bad school performance.
Thank you, Henry. Are there any other questions? Yes, sir.
Dan, how would you characterize, sorry, Paul Mountain Healthcare.
Hi.
How would you characterize the situation in Congress, and how would you characterize the situation in Congress and your prospects for getting something done, and what exactly are you asking for?
Thank you, Paul. Well, trying to describe what's going on in Congress, not only now, but just about any time, is challenging at the least. But I think I'm sure you know, that Congress is considering working on a package that would fix the Medicare physician payment methodology, and which has to be done by the end of the month, by March 31, unless they're going to do a short-term patch and maybe pick the issue up later on. We do know, and we've heard, and we've seen press reports that thanks to the advocacy of some members, the Children's Health Insurance Program extension will most likely be included in that package, at least for a couple of years. That program, it's not that it expires. Well, the authorization to continue funding it expires in September, on September 30th, the same day that health centers face their primary care funding cliff. And we have certainly, and we're proud to say, not only to celebrate our 50th anniversary, but to carry a message to Capitol Hill. We have about 2,500 people coming in later this week, in fact, starting tomorrow, who will be speaking with their members of Congress about this primary care funding cliff and the need to fix it. Now, we have no information on whether a health center component might be included in that package. But as I told another reporter a couple of days ago, we are fervently, profoundly hopeful that, in fact, that package will include a fix to the primary care funding cliff. And I've mentioned that term 3 times now. I want to mention one other thing. Not only does the cliff, the loss of funding, affect the Federal Health Centers program with a 70% loss of funding, there are 2 other programs, the National Health Service Corps program that provides scholarship and loan repayment assistance to medical and dental and nurse practitioner and PA students and others in return for service in underserved areas. Right here in Dr. Gary Wiltz, we're looking at one of the earliest products of the National Health Service Corps. He went out to serve, what was it, a 2-year?
3 years.
3-year obligation in 1981. He and I, we talk about it all the time. Why haven't you moved on? Maybe it's Arrested Development, but I think
it's the value water.
I think for all of us, more importantly, because if we asked everybody on this panel, why haven't you moved on? Because we love what we do, and we care deeply about the work that our health centers do all across the country, and also about the unmet need that continues on. So the National Health Service Corps and the Teaching Health Centers program, Dr. Wiltz mentioned that earlier, which today is supporting residency programs that train about 600 physicians at the current point. In 3-year residency trainings, all based at health centers. The National Health Service Corps, which is assisting, has placed and is supporting 10,000 clinicians across the country now. Both of those programs face a funding cliff that is 100%. On September 30th, unless Congress acts to continue funding, the National Health Service Corps will die altogether, and the Teaching Health Centers program will die. So, and we have wrapped all 3 together in what we call the primary care funding cliff, because every one of those programs, the Teaching Health Centers and the National Health Service Corps, are essential to the continued success of health centers. Long way of answering your question, Paul. We hope fervently, as I said, and profoundly, that Congress will heed the pleas of the people all around the country, and especially those 23 million people who are served today, because the alternative is unimaginable. Other questions? Yes, Abby.
Dan, can you talk a little about how in the states that did expand Medicaid, how that new source of revenue either mitigates or doesn't mitigate so much the funding cliff situation for those health centers?
Sure. It is ironic, actually, that among our 4 panelists here, only Henry is in a state that expanded Medicaid. We've got 3 others here representing the Good South, They're the good part of the South, which has steadfastly refused to expand Medicaid. So let me say a quick word, and then I'll ask each of the panelists to speak to how the decision to expand Medicaid or the refusal either alleviates or compounds the difficulty that they face with the health center funding cliff. I will tell you that in talking with colleagues at health centers around the country, what I'm hearing is that where the states have expanded Medicaid, it has brought an infusion of new revenue into the health centers, but has also resulted, and the first and best example of this was in Massachusetts under what they call Romneycare in 2007, resulted in a huge infusion of new people seeking care, many of whom, by the way, were and are still today uninsured folks who were getting their care elsewhere, but because of the changes in that state and the coverage plans and whether it was hospital-based clinics or freestanding clinics being overwhelmed, they had slowly pushed out their uninsured patient population. And so these folks ended up at health centers, such that 6 years after the Massachusetts program began its expansion, while the proportion of health center patients, and remember Massachusetts is sort of the epicenter, it's sort of oh God, I'm blanking on it, but it's like where the Muslims go. It's Mecca, the Mecca of the health center program. It was where the very first health center opened its doors. While the proportion of uninsured patients and health centers in Massachusetts had dropped from 38 down to 22%, the actual number of uninsured patients had grown. Instead of serving 400,000 people, they were serving over 600,000, and even at 600,000 plus, 22% was a greater number than the 38% of the smaller, the previous period. And that has happened. That's what I've heard from places around the country, is yes, it brought an infusion of revenue, but thank God we had it, because the doors are, you know, breaking wide open. And one other thing, and then I'll let Henry answer. Many of those who have come in have, and they're very fortunate, and we are appreciative of their good fortune, have gained coverage, many through the Medicaid expansion, many more through the exchange coverage. But when they come to the health center, they have deductibles and co-payments that are so high that, as one health center director said to me, Dan, they're pretty much uninsured for my purposes. Thank God, if they need specialty care or an admit, I can take care of that when I couldn't before. And that's a blessing. But for my purposes, they're virtually uninsured because we collect almost nothing. Henry, what's your story?
It's a very good question. It's a very complex question. And my answer is too soon to tell. What we do know is that we're seeing more patients who are entering the healthcare system in the city of Chicago, which we're very pleased to see, about 20% growth at Miles Square proper. So we're very, very pleased to see the growth in patients who enter our doors. You may ask, well, why is it so complex? Because not only are we seeing, you know, people getting access to health care, but we're seeing the payment model change. In the state of Illinois, we have a new governor, and the governor has proposed some rather extreme changes to the way health care is delivered in Illinois. So to get a glimpse of what I'm referring to, Google the SMART Act, and it's the law by which now patients will have a limit of 4 medications when they get treated in our health centers or in the state of Illinois overall when they're on public aid. So you have a push and pull on both sides of the equation. What it doesn't speak to is still those large number of undocumented patients who we're still committed to caring for. But it's also, as Dan explained, that it doesn't speak to also the churning of patients who fall in and out of insurance. Those patients who qualify choose not to because they don't want to have to pay the high premium. So from our perspective, being a year in, it is too soon to tell, you know, what the data will show us. But we're watching the data. We're glad to see more patients getting into care, but it is a dynamic process right now. Does that help you? Okay.
How about the three of you in the, I call them the hell no states?
Well, in Louisiana, where I refer to our governor as Governor Farrow because he won't let our people go into Medicaid, we have built it and they have come. And they keep coming. We've increased access. We've increased the hours of operation. We're open 6 days a week, 12 hours a day. We were very fortunate, as most community health centers nationwide, we are now out of old churches, old schools, old trailers. The National Service Corps has allowed us to expand the workforce, so we have capital that improve the facilities, and now we have workforce that is matching up with that, and now the funding, the operational side, which we all banked on as part of the solution, is not there. Patients don't know that. You know, they know us, and those who live in local communities, they know where we, and I had the good fortune of being a local elected official for a while. They know where you live. They can put their hands on you when you live in they know where you shop, where you worship, and they can find you. So they don't understand, you know, something coming out of Washington or the state capitol. But see that little logo? That logo was always our mantra. It's a picture of a home and a person with their arm wrapped around their family. We've always been a medical home. We're more than just a medical facility or clinical facility. It's always been the beacon in the communities that we represent. So are we going to be there? Yes, we'll be there. Can we do more, given more? Yes. And I think that's the point of the whole reason for the report. We've had an enduring legacy. We've proven ourselves. We can do much, much more. We're not the panacea, but we can help solve a lot of the problems in this country if we're continue to given the resources that we have been good stewards of. So, you know, the governors that in those states that haven't taken it, you know, we will find a way. We've always found a way in community health centers, and we will find a way. But we've got to get this fixed. There's no question. If we don't get it fixed, it'll be devastating, but we'll still be there. The capacity in which we're able to function may not be the way we want it, but we will figure out a way. And I'm confident that Congress, I mean, if you want to, I keep going back to the triple aim, no one else offers access, quality, and costs better than community health centers. It's America's best investment, and it has to be, continue to be funded.
We got to wind him up and send him out on the road. We have reached an hour now, and while any of us and all of us would be glad to answer any further questions, I think it'd be appropriate for us to close up this briefing now and let you, those of you who need to, get on your way. But we'll be happy to remain and answer further questions. Thank you so much for coming. Really appreciate it. And take care and have a great day.
Thank you.